discussing about ठीक है. Oh, so okay, we were discussing about the rectal route, right? And we saw that why the rectal route is having more bioavailability than the oral route. Now, the another part of the enteral, we were discussing enteral route of administration, which was having, like, please, everyone try not to do anything on the screen, okay? It's moving. Okay, enteral. So it is oral, rectal, or sublingual. So we discussed oral, rectal. Now we'll be discussing about sublingual. Now we know what is sublingual. It's nothing but when we are putting the drug either beneath the tongue. We are putting the drug either beneath the tongue or between the teeth and mucous membrane. Okay, so now what will happen? Yeah, I was asking this question that why there will be quick absorption if the drug is taken sublingual. And there is the simple concept which we discussed for oral and rectal. Can anyone answer me? Can anyone answer why it will be quick absorption through the sublingual one? Anyone? Okay, no one. So, because this drug will be going into the systemic circulation. That's why. Now, what is happening? This is skipping the first pass metabolism. So, what we have to think is whenever a drug is going to have first pass metabolism, the bioavailability will decrease. Whereas if the drug is going through bypass of the first pass metabolism, then what will happen? The bioavailability will decrease. Oh, sorry, increase. Okay, so this is all about the enteral one. So what we are doing, we are discussing about the route of drug administration, and in that we saw that there are three types of like three ways of administration of the drug. And what were that those three ways? Those were enteral, parenteral, and topical. Now we have discussed enteral, that is ORS. Now it's time to discuss what is parenteral. So there is a small trick for parenteral route of administration. And we know what is parenteral, right? Parenteral is anything except when the drug is like any other pathway other than the enteral. Any other, any other pathway other than enteral is what? Parenteral. Okay, so there is a trick. So we know all the intra things, all the intra things. Just a minute. Mm. All the intra things are going to come in parenteral, either intravenous, either intra arterial, or anything. So we have a trick for it. Intra, just remember intra, and then vampire. Vampire. Now the spelling will be little bit different for vampire, so don't bother that. We can just remember it. Okay, through vampire. Vampires. Okay, now what is this vampires? Now we will be discussing that. So I said put intra with all of that. Either intravenous, intra arterial. Now there are two A, arterial A, or else the articular, either in the artery or in the joints. Okay, now I am for either intramuscular or intramedullary. This is also two. P for what? Intraperitoneal. E for what? Epidural. AR is again articular, and A is ethical. And S is what? S is subcutaneous. Okay, so S is separate, subcutaneous, not intrasubcutaneous. It is subcutaneous. So what we have to remember? Intra, vampire, sub and subcutaneous. Okay, so this is all about this. What? Parenteral route. Now again, what I said, for all of this route of administration, they expect from us is we should know the merits, demerits, and the examples. So let's see for each one of them. Okay, so let's suppose if I'm talking about intravenous. Okay, now we know what is intravenous, when the drug will be going into the veins. Okay, so that is intravenous. Now what will be the merit? 100% bioavailability is the merit. Now why it is? Because the drug is bypassing the first pass metabolism. What the drug is doing, it is bypassing the first pass metabolism. That's why the bioavailability is 100%. But there are demerits, isn't it? We know, can we take the intravenous injections by our own? No. That's why self injection is not possible, is a demerit. Aseptic conditions can be followed, as well as it's a risky route. Okay, so if we are giving any high concentration of drug, etc., then it is risky. The example can be morphine. Morphine can be taken intravenous. Okay, so this one is the first one of the parenteral route. Now another one, intra-arterial. Now if I'm telling intra-arterial, what does it mean? Into the artery. Okay, so the drug is going into the artery. Now what will be the benefit? Definitely rapid onset of the action. Okay, and this arterial is very good for diagnostic studies like angiograms. Okay, it's very helpful in that. But what is another demerit? Definitely it's painful, it's risky. Aseptic precautions can be there. Okay, example for it can be an angiogram. Okay, now we can go for another one. What is the another one? It can be subcutaneous. Let's take subcutaneous. Now what is subcutaneous? We know. Where are we giving? Either in beneath the skin or connective tissue or beneath the fat. Okay, so it can be either skin, connective tissue, or fat beneath the dermis. What below the dermis, the fat is there, no? There we can give. Okay, now what can be the merits? Definitely, it is uniform and it will be producing sustained action. Very important. Uniform and sustained action, and it minimizes the risk of IV. Okay, another thing it is, it will minimize the risk of IV. Now what are the demerits again? But the the patient can't take by their own. No, so sorry, it can be taken. The absorption is slower. This is one of the demerit, and only non-irritant drugs can be given. Okay, now example is insulin. The example for it is insulin. Insulin. Okay, it is given subcutaneous. Another one, intramuscular, that is into the muscles, skeletal muscles. We have to mark this point, into the skeletal muscles, intramuscular. It now, what are the merits? Mild irritants can be given in the muscles. Okay, but we can't directly give into the arteries or veins or subcutaneously. Okay, so mild irritants can be given in muscles, and the absorption is faster and uniform in case of muscular administration. Okay, another thing is this, the demerit is self administration cannot be given, and chances of abscess and nerve damage are there. Okay, now the another part is intraperitoneal. Intraperitoneal. Now, what is intraperitoneal? Whenever the drug will be administered into the peritoneal space. Peritoneal space. Then that is intraperitoneal. Now, it has rapid absorption, as well as it is used in infants. It can be used in infants. Okay, and for any peritoneal dialysis we use it. Okay, the demerit is of course painful, it's painful. Okay, and risk of infection is there. Aseptic conditions are required for it. Okay, now another part, yes, another type is intra ethical. Now what is this? Intra ethical. It is the drug is administered into sub uh, spinal subarachnoid space. Spinal subarachnoid space. Okay, again, what will happen? Definitely it is going to bypass, it is going to bypass the blood brain barrier. Okay, and it is used as a diagnostic aid also. And The demerits are, of course, aseptic precautions needed to be followed. It is very painful and risky, and it requires experts for administration. Now, the another one is intramedullary. When the drug is administered into bone marrow, then it is intramedullary. Okay, not in the medulla oblongata. Okay, so the drug is administered into the bone marrow. That's why it is called intramedullary. Now, what is the merit? It is having fast absorption, but again risky, painful, and aseptic precautions are required. Another type we can see is what? What is the another type? Another type can be intra-articular, isn't it? So what is intra-articular? Definitely we are giving the drug into any joint, specifically the synovial cavity. In the synovial cavity, then that is intra-articular. Okay, what are the benefits? It used for pain management, joint mobility. It will endure higher concentration in a localized area. But there are demerits. What are the demerits? Definitely it's risky, it's painful, and of course aseptic precautions are required. An example, a beautiful example is hydrocortisone. Hydrocortisone. Okay, it is given in the joints. Now, epidural. What is epidural? When the drug is injected through the small catheters, like catheters are used, and it in the epidural space it is given. Where? Epidural space. That's why it is epidural. Okay. Now, epidural. What is the merit? It will increase, increasing you like for pain management. It is very good. Okay, definitely it will be painful and risky, and aseptic precautions are required. The last one is inhalation. Definitely it is a parenteral route. It doesn't comes under enteral route, so it is inhalation. Now, inhalation is what? Either through the nose or mouth. Through the nose or mouth the drug is taken. Okay, now it will be definitely now, yeah, when I'm saying through the mouth, then many of you might be thinking, oh, if we are taking through mouth, then it is enteral, right? But it is not. Why? Because we are inhaling it, not chewing or taking it into the git and blah blah blah. Okay, so it's an inhalation is when the drug is inhaled through nose or mouth. Okay, so it will have rapid delivery. It will the bronchodilators which we are using is so it can be given through inhalation. But the demerit can be drug may cause cardiac toxicity as it enters heart through the pulmonary veins. These pulmonary veins can take the medicine to the heart, so the heart is in danger whenever we are taking inhalation. Okay, example is salbutamol, which is a general anesthetic. Okay, so what we were dealing with? We were dealing with parenteral route of administration. We know this routes of drug administration is of three types: enteral, parenteral, topical. Enteral, ORS; parenteral, intravampires; and topical. Now let's move towards topical. So now this topical is again of four types. And what are these four types? Let's see that. So the last one in the routes route of drug administration is topical. What is it? Topical. Now, for topical, again we have a trick. I don't know we can call it as trick or not, but it is tweak. Topical is tweak. Okay, so we can just remember it like this. Topical is tweak. What is tweak? Nothing but transdermal. It will be transdermal. It can be vaginal. It can be an inaction, or it can be conjunctival. Okay, conjunctival. So these are the route administration, like through the topical route administration can be done. If I talk about transdermal, what is it? We recently discussed in the drug dosage form also that we have this transdermal patches, which was coming under what? A dosage form which can be given externally, right? So that can be given, and what it will do, it will be there the drug which we are applying, it is skin there it for sustained period, like it will sustain for a period of time. Okay, now if I'm talking about conjunctival, what will happen? The drug is administered to the conjunctiva and it will produce what? Local effect. If I'm talking about inaction, what is that? It is rubbing the drug over skin. Okay, it's basically rubbing, or you can also say massaging over skin, like which will create a warmth. And this warmth creation will do what? It will enhance the absorption of the drug through the capillaries. Why? Because the capillaries will be dilated, and definitely it will increase the blood flow. A very beautiful example given by Indulekha ma'am in the class was minoxidil. Minoxidil. Now this minoxidil is applied externally so that the blood level increases, sorry, there is increased blood flow. And when there is increased blood flow, then what will happen? The hair growth, the follicles will grow more. Okay, so it is there. So this is all about the routes of drug administration. I'll just give a short review of this. What was it? Routes of drug administration is of three types. The first one, enteral. The second one, parenteral. The third one, topical. What is enteral? Anything which is giving into the GIT is enteral. That is ORS, oral, rectal, sublingual. The second one is the parenteral. Anything except or without entering into GIT, that is parenteral. What was the example? Vampires. What was that? Intravenous, intra-articular, sorry, intra-arterial, subcutaneous, intramuscular, intraperitoneal, intraethical, intramedullary, intra-articular, epidural, and of course inhalation. Okay, and the third one is what? It is topical. Topical examples are what? Transdermal, vaginal, inaction, and conjunctival. So this was all about the routes of drug administration. So till now, what we discussed, let's have a recap from the beginning of the class. We discussed what is pharmacology. We discussed it's the study of drug. Then we discussed how we are going to administer that drug. Either we discussed what will be the form and what will be the route. Okay, now another point that we discussed, what if there are two people, that is drug and body, then definitely the interaction will be there. What this D is doing to B and what this B is doing to D. So whenever we are talking about D, remember dynamics. First, if D comes, what D is doing to B, then dynamics. That is pharmacodynamics. If we are talking about what the body is doing to the drug, then it is pharmacokinetics. So now it's time to discuss what is pharmacokinetics and what is pharmacodynamics in detail. Okay, so I'll be just starting it. Just give me 1 minute. We'll start pharmacokinetics. Okay, so let's start. So as we know, I was not speaking. Okay, fine. So let's see what is pharmacokinetics. I said whenever D will come first, remember about dynamics. What drug is doing to the body, then it is dynamics. But when what body is doing to the drug, this is pharmacokinetics. Now we can imagine it like, let's suppose something is coming towards you. Okay, now what you are going to do with that particular thing, that is called kinetics. Okay, now we know from like the knowledge of physics, the kinetics is not like when we are doing some work or something, right? So what we are doing with the drug, that is what pharmacokinetic is all about. Okay, whenever someone comes, there is a phrase or there is a word which is used in Urdu, and that is adab. What is that? Adab. Now, like, although it is not exactly adab, what the body does to the drug, but we can remember it as me. That is ADME. So remember very well, whenever the drug is going to come towards you, what you have to say? You have to say adab. So what you are going to do? You are going to do ADME. Okay, now what is this ADME? Let's see that. Okay, so don't forget adab. When you have to say adab? Whenever the drug is going to come towards you. So you will be saying adab. Now, what is adab? Adab is A for absorption, D for A for absorption, D for distribution, M for metabolism, E for excretion. Okay, now we will be seeing all of these terms in detail and in a way where we can write this question. Let's suppose this pharmacokinetics comes for 5 marks, then we will discuss all of the things what we can write in 5 marks with little bit of explanation at certain parts where I feel like it's very beautiful. So we can do that. Okay, so absorption. Now, what is absorption? We know it's nothing but biotransport. What is biotransport now? Isn't it? So, biotransport is nothing. Let's suppose that this is the site of administration. This is the site of administration. Now, from this site, when the drug is taken into the bloodstream, when we are taking the drug into bloodstream, then this is called absorption or biotransport. Now, how this transport happens in the body? First, we will be seeing that. Okay, so let's see how this transport happens in the body. So, that biotransport, how the body is going to take the drug into the blood, we will be seeing that. Okay, so biotransport is either passive or it can be active or there can be special movements. Okay, so either it is passive, active, or special movements. Now we know passive. What is passive? Whenever no energy expenditure is there, it is called passive. It is of two types, of course, that is simple and facilitated or by a carrier. Okay, simple one is, let's suppose you jumped into a river and you are going with the flow of the river. That is simple. And the example can be sodium channel. Just be focused, it is sodium channel, not sodium potassium pump. Okay, potassium channel, oxygen, CO2, these go by simple transport. Another one is facilitated or carrier transport, where protein carriers and etc are needed to take the thing, but there is no expenditure of ATP. Paisa nahi lagega. No expenditure of ATP. If we are talking about active, here definitely there will be expenditure of energy. Okay, we have to expend some energy. Now this active is also of two types. First one is primary active transport and the second one is secondary active transport. Now what is primary active transport? Wherever you are going to spend ATP. If you are going to spend your ATP, then it will be primary active transport, and the example can be sodium, potassium, calcium, hydrogen, chlorine, etc. Blah 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 blah. Many things in the body which are transported by the expenditure of ATP. Okay. Now the another transport is secondary active transport. What is that? What happens in this? If you are not spending any ATP, then what you have to do? You have to bring someone who can take your load there and you take their load here. Okay, it means it is a co-transport. Co-transport. Okay, so you need a co-transport, then it is secondary. Okay, so first of all, either you have to spend money, it is primary active transport, or you take someone who can take your load here and you will take their load in there in so it will be what? Secondary active transport. Now there are another type of transports. What are they? They are special movements, either bulk flow. What is bulk flow? See, now there people may have this doubt whenever like the moment I will explain bulk flow, there will be people who will be having a doubt. Let's see whether you have a doubt that or not. Okay, so what is bulk flow? Bulk flow is when in large quantity things go from higher concentration to lower concentration. What is it? What is bulk flow? When in large quantity things go from higher concentration to lower concentration. We know very well in active transport things are going from low concentration to high, whereas in passive from high concentration to to low, then again what is this again, concentration gradient is coming. So the important point that should be marked is large quantity. Okay, this is how it is different. Okay, so now let's move forward. Now what we have, yeah, bulk flow. After that, endocytosis, exocytosis, and osmosis, these are also a way of transport. So what we learned over here, we learned that, what we learned that how the transport happens. Basically what we are learning, pharmacokinetics. So in pharmacokinetics, what we were learning, adab, what is that? Absorption, distribution, metabolism, and excretion. What is absorption? Absorption is nothing but transport. Whenever the drug is coming into the body, now how we are going to take this drug into the blood, that is absorption. There we have several ways in which we can take. That is that is what biotransport. That is passive, active, and special movement. Blah blah blah. Okay, now let's move and see what is. Here we were seeing how it is happening, right? Biotransport, in biotransport we were seeing how it is happening. In, now we will be seeing where it is happening, where this transport is happening, from where to where. Okay, so first of all, the transport can happen through the GIT, that is gastrointestinal tract. Okay, now a very beautiful thing that we are going to learn, maybe I think there will be shortage of time, so not in this class, but now what happened to the screen? कहाँ गया? Yes. So if we are talking about GIT, now remember one key thing. This is a very crucial thing, because if you understand this thing, no, it will be all clear that which drug is going to get absorbed and which drug is going to get excreted. All the modern drugs. This is the core concept. What is that? First one, non-ionized and lipid soluble. Any drug having these two features, no, what, which two features? These two features. What are these two features? These two features are non-ionized and lipid soluble. Then that drug will be what? Capable of getting absorbed more. And if you change their property, if you make it ionized and water soluble, now it will have more property of excretion, that we'll see in excretion. Okay, so what we were dealing with, where this thing is happening, where the absorption is happening. So the first part was GIT, where the absorption is happening. Okay, so how it is happening? So we'll see in GIT we already discussed this concept, and that was that in GIT, in gastrointestinal tract, either we will have first pass metabolism, or bypass of the first pass. Okay, or bypass of the first pass metabolism. Now what was that? Let's have a quick recap on that. What is first pass metabolism? So let's suppose again, oral route, fecal, cells of the intestine or the GIT, then our beautiful liver, then the portal vein, and then the systemic circulation. Now what will happen? This, there will, a drug will be coming, oral, fecal, portal vein, liver, and systemic circulation. Okay, now this drug is coming, getting absorbed, going to the portal vein, going to the liver, and then getting metabolized by the cytochrome P450 and changing its features and getting and reducing its bioavailability. Okay, whereas if a drug directly gets absorbed into the, let's suppose a drug came and this drug directly got absorbed into the systemic circulation. This is one way. Sorry, this is this is one way. This is one way, that is the first pass, and this is the second way. Either you take sublingually or you take any way of through rectal or through sublingual, and the drug is getting passed directly to the systemic circulation. Then what will happen? Definitely it has bypassed this route, isn't it? See, it has bypassed this route. Oh shit. So what will happen? it will definitely not get changed, and the bioavailability will be higher. Bioavailability will be higher. So this is how, this is the place where the drug is getting absorbed, either directly through the intestine, or through the intestinal tract into the portal vein, then to the liver, and then to the systemic circulation, or directly from mouth and rectum to the systemic circulation. So this is how the medicine from this part of administration, how it is going, where it is going, it is going into the bloodstream. This is what we call absorption. Now let's see another way or another site where absorption happens. First we saw in GIT, we are taking either ORS, oral rectal, or sublingual. We saw either it have to go through first pass metabolism, or it have to go bypass of the first part metabolism. Now the second one is parenteral site. Let's suppose I gave a drug, through, I gave a drug through parenteral route. Now what should I expect? Definitely this will go into the systemic circulation directly into the systemic circulation. So let's suppose this is your head, this is the neck, and this is your arm, and this is your beautiful deltoid muscle. Here an injection was given, and now this has gone into the directly into the systemic circulation. So from the site of administration into the bloodstream, from the site of administration into the bloodstream, it has gone. It means the drug has got absorbed. Okay, so this was another way. Now the another way is, the first one was GIT, second parenteral site, the third one is lungs, through the lungs. Now what happens? The mucous membrane of the trachea or the lungs is going to absorb the medicine. Okay, and then it is directly going to give into the veins over there. So the blood will reach from the mucous membrane, or the site of administration is what? Either it can be inhalation, right? So we can give directly it through inhalation, that is the site of administration, and the drug will go into the bloodstream. The last one is the topical administration. Now what happens, our skin is having keratin, we know skin is having keratin, but we also have a beautiful dermis which is helping us. Now this keratin is not allowing, this keratin is evil, it is not allowing the, it is basically a barrier, it is not letting the drug to go. But we have a beautiful dermis which is quite permeable, it is quite permeable because it is lipid soluble, and the drug which we were talking about was lipid soluble drugs mostly, so this will get easily absorbed. So what we discussed? We discussed about absorption. So I hope that absorption part is clear very, very well. So what we are discussing? We are basically discussing pharmacokinetics, what the body is doing to the drug. So whenever the drug is coming to you, what are you going to say? You are going to say adab. That is absorption, distribution, metabolism, and excretion. Among this absorption, what we learn? What is absorption? It's nothing but from the site of administration to the bloodstream, how the blood goes. This is absorption. Basically, when the drug from the site of administration reaches to the blood, this is absorption. Okay, then we learn the ways of transport, how the transport happens. Then we learn where the transport happens. Where the transport happens? Either GIT, and if it happens in the GIT, then we learned upon two metabolism, that was first pass metabolism or bypass of the first pass metabolism, then parenteral, then lungs, then topical. So this is where the absorption happens. So this was all about absorption. Now it's time to go towards another part of adab, that is distribution. Distribution. Now what is distribution? See, we learned what, when this is the site of administration, right? We are giving drug, this is the site of administration. Now from there it is going into the bloodstream, this is the bloodstream, it went. Now from the bloodstream, going to the different places, from the bloodstream going into different places. You can see it's a pattern of scatter, isn't it? And what this is, what we call distribution, a pattern of scatter, a pattern of scatter. Okay, so what is distribution? Nothing but taking the drug from the bloodstream to different parts. But there is a challenge over here, and that the name of the challenge is barriers. The name of the challenge is barriers. So we are going to see what are these barriers. So you might have learned, you might have heard multiple times name of these barriers. Now today let's see what are these barriers. Okay, so see what happens, what I say, site of drug administration into the bloodstream, from the bloodstream to the different places, but a challenge called barrier. What are barriers? These barriers are nothing. We will be learning about three types of barriers. One is plasma protein barrier, another is blood brain barrier, and the third one is placental barrier. Okay, so these three barriers are there which we are going to deal today. That is plasma protein barrier, blood brain barrier, and placental barrier. Now, when you will learn this plasma protein barrier, you will be amazed. It's very beautifully, like how beautifully it is working, we'll get to know. Okay, so the thing is, we are talking about distribution, we are talking about barrier. Now we know if there is a barrier, this barrier may be having it will definitely have a constituent, right? It will be made up of either water molecules, or else it will be made up of lipid molecules, isn't it? Either it will be loving ionized thing, or it will be loving non-ionized thing, isn't it? So similarly, by this there is an important point, and that is the factors that affect the barrier. Okay, what are the factors? The first factor is lipid solubility. How much your drug is soluble to lipid? Why? Because the cell membranes all are lipid, so they love lipid. So your, if your drug is more lipid soluble, they will welcome it very nicely. The second part is ionization. If your drug is ionized, then definitely it will have what, it won't be welcomed so well. It needs to be non-ionized. Why? Because ionized molecules are always active, and people don't like interaction in their thing. They like inert things. Why? Because when an inert thing will come, what will happen? It won't change their environment, right? So they don't like change. It's the nature of the nature, we don't like change. So they don't like ionized things. So if it is more ionized, definitely there will be difficulty. If a part or a tissue is more vascular, then what will happen? The distribution will be higher, because more blood, more drug. Okay, more the blood will go, more the drug will go. Okay, so this will happen. The another part is binding to the plasma or cellular protein. How much efficient it is to bind to the plasma or cellular protein. Now this is the part we are going to learn in a bit detail. Let's see, you will definitely enjoy that. Let's see that. Okay, now what is it? Okay, now what is plasma protein barrier? So let's see. Plasma protein. I think only less, like only 1.5 minute is left. So this won't be completed, this plasma protein barrier. So should I stop here? Or anyone have any doubt or any suggestions? Please let me know. We can discuss that in 1.5 minute, because this plasma protein barrier needs a bit of time to be explained, and unfortunately we are not able to finish pharmacokinetics completely. We have been only at till distribution. So I think we have to stop because it won't be completed. Please tell me everyone, like what should I do? Should I stop? I have to stop actually, because it will be getting ended. Yes, any doubts, any suggestions? Guys, you can speak. I am not a teacher, I'm your friend. Please speak to me.
हिंदी में समझा दें।
Huh?
हिंदी में समझा।
Okay, fine. So I think that no one has anything to say. So I'll be ending the session here. Whatever suggestions and whatever reviews are there, please give me that. How can I improve